Okay, thank you. Good evening to you all. Welcome to the discussion sessions of the program presented by the Faculty of Dentistry, RCSI, entitled Effective and Safe Oral Surgery in a Post-COVID World. This is an online, practical-based course, and you're very, very welcome here. I'm Professor Albert Leung, Dean of the Faculty of Dentistry, RCSI. I'm also a Professor of Dental Education at University College Eastman Dental Institute. Under normal circumstances, this course would have been held in Dublin, would have been held in a brand new facilities, brand new clinical skills facilities, prize-winning facilities in Dublin. But of course, we are not in normal times at all. You would have been visiting St. Stephen's Green in Dublin. But there is nothing normal here because I'm sure it is very fair to say that we all have had an unprecedented and a challenging year. Just a short 10 months ago, none of us would have heard about COVID-19. And yet, this has been a dominating force in our activities in the year 2020. The Faculty of Dentistry has been facing these challenges with a series of teaching and learning innovations. We try our best to continue to deliver examinations, assessments, and aspects of education to everybody around the globe. We have actually had a lot of successes this year. Despite these challenges, the instance of our online examinations, postgraduate lecture series, delivery of specialist training in areas of pediatric dentistry in conjunction with Hamad Medical Corporation in Qatar, and other education and online initiatives as well, like any scientific meeting, getting back to school seminar, and the likes of that. Today is no exception. This is the first time that we ever deliver flipped learning in this particular manner. And I hope that you have found the program entitled Effective and Safe Oral Surgery in a Post-COVID World interesting and useful. For housekeeping business, you're very welcome to ask questions live. When I say live, I mean that in your screen on the bottom, in the middle, there is a box, Q&A box. If you type your questions in, it will then filter through to us, and we can then start to answer the questions or comments that you may have. So this is a very, very interactive session. With us this evening on the live question and answer sessions are our panel of experts. Our first expert is Dr. Andrew Bolas. Dr. Bolas is a principal dental surgeon of HSE in Sligo, Ireland. He is a former president of the Irish Dental Association, specialist in oral surgery, specialist in radiology, and also he's a board member of the Faculty of Dentistry, Royal College of Surgeons in Ireland. Our second member of the panel is Professor Jerry Kearns. Professor Kearns is chair of Education Committee at the Faculty of Dentistry, RCSI. He is a consultant oral and maxillofacial surgeon at St. James's Hospital and Crumlin Children's Hospital in Dublin. He is also a past dean of the Faculty of Dentistry, RCSI, and he is also a member of the Dental Council in Ireland. Our third expert this evening is Dr. John Marley. Dr. Marley is the immediate past dean of the Faculty of Dentistry of the Royal College of Surgeons in Ireland. He is a consultant in oral surgery at the Queen's University of Belfast School of Dentistry. He was previously chair of the Board of Examiners in the Tricollegiate Examinations in Oral Surgery for RCS England, as well as their specialty advisor. John was also on the training program, being Director of Oral Surgery for Northern Ireland. So these are our experts. So you're very welcome to type in any questions that you would have, and then we would be very, very happy to discuss and answer any question that you may have with the course in any aspect of oral surgery. Okay, let's move into the questions situation now. Our first question, if I may direct the questions to Dr. Marley. In terms of surgical planning, what do you think are the key takeaway messages for dental practitioners? This is a question from the audience.
Thank you very much, Albert, and thank you for the very kind introduction, and welcome. Can I extend my best wishes to our delegates who are joining us this evening from across the island of Ireland, the UK, and the world, in fact. So from a point of experience, I would say really it's your day-to-day practice. Just keep doing what you do in your day-to-day practice. Get the basics right. And by that I mean the plan, whatever plan you're going to arrive at, will be a function of what you've learned on the diagnostic pathway along that. So good history taking, good examination, good use of special investigations. And I'm sure Andrew will talk a bit on that later on. And eventually a derivation of the correct diagnosis. So you need the correct diagnosis clearly to get the correct plan. And it's only when you have that you can implement that plan. And so my view on this would be, once you have done that, then you're going to have to decide based on your assessment of the surgical task in hand, whether you're going to do it or whether someone else is going to do it, and make sure that the patient is aware of the implications of your plan through informed consent, and taking that in stages. So really, once you've undertaken that and made sure that the plan is completed as you had devised, then follow-up would be important. So all of these things, I think, contribute to good surgical planning, and they're not foreign to us as practitioners, whether we be, for the most part in this audience, generalists in what we do. We do this every day of our working life. So it's no different, to my mind, in surgical planning for Exodontia. I'm not sure whether any of my colleagues would want to add to that.
Thank you, John. That's a very good summary of where we are with regard to planning. I often think we should think about patient factors and procedural factors, as you point out. So, for example, if you have a 10-year-old anxious child who has to have a lower right first molar removed, this is a completely different kettle of fish to a 20-year-old person with the same technical procedure. So your summary of patient factors and surgery factors are so important in our assessment, and we must take into consideration all of those separate factors before arriving at an appropriate surgical decision. Thank you, Albert.
Okay, thank you very much, Sherry. Now I'm going to repeat a little bit of housekeeping business, because I've noticed that since our start there, quite a few of our colleagues have joined us live. You're very, very welcome to this question and answer sessions. And if there are any questions that you need or you like to express there, at the bottom of your screen there is in the middle a Q&A box. If you click on that, if you type anything in and you put send, then we'll be able to get the message through as respect to what you would like to discuss. The next question from the audience is actually directed to Dr. Bolas, Andrew. Extractions of teeth is a very, very common clinical situation that we face. But when would you consider taking a cone beam CT scan prior to an extraction? When would that be essential? Andrew, thank you.
Thank you, Albert. I'll be honest that I suppose with cone beam CTs, the first thing everybody should take into consideration is the ALARA principle. In other words, keeping the radiation dose to the patient as low as reasonably achievable. I much prefer what they call the ALADA principle, where it's as low as diagnostically achievable. That said, I don't think it's appropriate in many cases to take the cone beam first. I think really where it should be used, or where it's best used, is where our plain films give us some information or give us a suggestion that we need more information. So, for instance, where you have a lower third molar and the panoramic radiograph shows the tram lines of the inferior dental nerve disappear as they come close to the roots of the molar. In those cases, it may be of benefit to the treatment planning to know exactly where the nerve is. And in a similar fashion, sometimes we take periapicals and we see something on the periapical that makes us suspect there's something going on. So, for instance, with an upper molar and the maxillary antrum, we might think the root is in the antrum, but we can't be too sure. So I think really the cone beam should be used as an additional tool to get a good diagnosis, going back to what John had said at the start, a good diagnosis. And it's a tool that can be used to our advantage. Unfortunately, it's also a tool that can be used to our disadvantage, because a cone beam will often give you more information than you actually anticipated. And of course, we have to look at the scan volume and look at all the information that's there, and then try and interpret what we're going to do. So in an oral surgery situation, it may be where you're planning an extraction. It's great. You can bring the patient back next week. But if the patient's actually in the chair, it may actually give us too much information and take too much time to look at it. Thank you, Albert.
Thank you very much, Andrew. Thank you. I think this is a very important answer in relation to the practice of radiology, of when to use and when not to use cone beam CT and what the advantages and limitations are. The next questions from the audience is directed to Professor Kearns, Jerry. As far as removal of bone is concerned, does the air rotor handpiece have any role in the surgical extractions of teeth and roots, and what may the limitations be, Jerry?
Thank you very much, Albert. We have to be very cautious about the use of the air rotor in surgery, and certainly once we lift a mucoperiosteal flap, the air rotor should not be used under any circumstances because of the risk of development of surgical emphysema. So we're all taught as undergraduate dental students this is not an appropriate thing to do, and indeed over the years we will from time to time in the hospital see patients presenting who have had the use of an air rotor following the elevation of a mucoperiosteal flap. However, there may be a role, for example, in this situation. So we're taking out let's say, for example, a lower first or second molar tooth, and the crown is fractured, and we're left looking at a socket where we're looking at a mesial and distal root. There has been no elevation of any mucoperiosteal flap, and in that circumstance, I feel that an air rotor is a very helpful adjunct to sectioning the roots and allowing us then to remove each root separately as if we were removing a premolar. So the only circumstances, in my view, where an air rotor may be indicated is before a flap is elevated, to allow us to section the roots, to allow those roots to be elevated separately. So I think that'll be a summary of an answer to that question, Albert. If John or Andrew have something else to offer, that would be good. Mm-hmm. Thank you.
Yeah.
Yeah, if I could jump in there, if I may, certainly with the advent of, and remember this is a fluid situation, and lots of guidance that comes out is live guidance with subject to alteration. And within the UK context, those delegates who will be listening in and watching us from the UK, they'll be aware that with the guidance on follow time, clearly there will be an implication for the use of handpieces beyond 60k rotation. So you want to be aware of that, because that clearly with the guidance is going to prolong your follow time. And the use of straight surgical handpieces, the handpiece for the job that we are in terms of oral surgery, is your best way forward in this. But I would echo what Jerry has said.
Yeah, certainly could agree on this. I think this is also important for us to note that in relation to the latest guidance and publication from Public Health England, in conjunction with the Scottish and the Welsh and the Northern Irish counterpart, for COVID-19 infection prevention and control in dental appendices, the 60 ref per minute is an important threshold in relation to aerosol generation procedure and the risks that is involved here. So it is very, very real here. Thank you. The next question is directed to Dr. Marley. So I'll just have a quick look here then now, which is that, Dr. Marley, this is one of your lectures that you have given before about decision-making process on what step to take or not to take if a root tip breaks off. The question here is that you mentioned about the amount of tip left is a very important factor to consider whether you remove it or not, as well as whether it's infected. If you decide to leave a non-infected tip of the roots, what do you say to the patients?
That's a very good question. I think the first thing that you say should have been said in advance, i.e. before the surgery, that as part of your informed consent, you would, certainly in my practice, I would always say there's a risk of leaving a fragment of tooth behind. In this scenario, this is a vital tooth, presumably maybe removed for orthodontic purposes or maybe third molar surgery. Nonetheless, it would be important to have noted this in advance of the surgery so that it comes as no surprise. Because what you tell the patient, of course, in advance is an explanation, whereas everything you say afterwards could be construed as an excuse. So in terms of the apical portion, clearly if it's belonging to a vital tooth, then I don't see any issue in terms of leaving that. There are circumstances, of course, where I would be preferring not to do that. For example, non-vital tooth or associated pathology, granuloma or cyst, or for example, in patients who are of medical risk. Certainly in days gone by, we would have talked about the patients who were at risk of infective endocarditis. But I think certainly where there's infection, the root has to go, all of it has to go. But in the vital tooth scenario, I would be less pushed on that. But I think the takeaway message from this is make sure the patient is aware that this is a risk and this is how you would handle that risk if it were to happen. Clearly, the length is important, and only because it's more likely to become exposed with time. And therefore, we talk about the apical third, because that's very unlikely to become exposed due to general bone resorption and subsequent exposure of the root.
That's great. Thank you very much, John. Thank you very much, Dr. Marley. The next question we have is directed to Dr. Bolas. The question here is that COVID is a real risk as far as a lot of patients are concerned. There are lots of carriers, there are lots of COVID positive patients, whether you know it or not. So because of this, is it actually safe for us to take intraoral radiographs?
Thank you, Albert. If I'm being honest, back in March when we went into the first lockdown, we very much avoided taking intraoral radiographs because the advice at the time was if the patient coughs or anything, it puts you at risk. And of course, we had a sparsity of appropriate PPE. I think at the minute, again, if we're wearing the appropriate PPE, there's very little risk from taking intraoral radiographs. We certainly come across patients who gag a lot when you're taking a periapical, especially of posterior teeth. But you tend to find that people who gag don't necessarily cough during the process as well. So the chances of them creating an aerosol or droplet spread are relatively low. So at the minute, I'll be honest, we tend to take a lot of radiographs just with aprons and the appropriate mask on and goggles, but it seems to be safe enough. And you also have to weigh up, the additional information you can get from an intraoral radiograph as compared to an extraoral alternative would probably stand you in better stead, because it may avoid the aerosol that you're going to create later with the surgical procedure.
Okay. Thank you very much, Andrew, for the answer. I have a question for Professor Kearns there. Taking teeth out is a risky business because you can always break or fracture a root. On occasions, we'll leave the roots behind. On occasions, we will have to intervene. In your assessments, where is the borderline and what are we looking for telltale signs as to whether we should leave things behind or whether we should intervene and continue to chase the broken roots?
Thank you, Albert. I think it's a very important question. I think John Marley has alluded to that a little while ago. One of the important factors is the tooth infected? Is this an abscess tooth, and is there some infection associated with the root fragment? If that's the case, well, then we have a commitment to remove that root fragment for the patient. If the tooth is a vital tooth, again, for example, being removed for orthodontic reasons or a third molar, and there is no infection related to the pulp or the periapial area, the small piece of root fragment, approximately 1/3 of the root, can be left in situ. I think this is very, very important if we talk for a moment about impacted mandibular third molars, because it is always, in my view, better to leave a small root fragment behind than explore the socket in oftentimes a challenging area and perhaps put the inferior alveolar nerve at risk of trauma. So in particular, related to third molar teeth in the mandible, if a root fragment is left behind, I think it's prudent to leave it there, in particular if it's close to the inferior alveolar nerve. But once again, to underline what has been said earlier on, we should give the patient an explanation beforehand, in as much that the roots are lying close to the nerve, and if one of them breaks off, we're going to leave it behind. Because, again, what John said, what you say before a procedure is an explanation. What you say after a procedure is an excuse. So the issue of informed consent with regard to pursuing retained and buried roots is very, very important. Thank you, Albert.
Thank you very much, Jerry. Thank you. We have a question for Andrew. Andrew, when radiographs are taken, according to the rules, reports should be written. But do I need to write a report for all the radiographs that I take, or only when the radiograph that I have seen something abnormal for oral surgery?
Thank you, Albert. Certainly at the minute within the Irish legislation, and I'm speaking from the Republic of Ireland, is that every radiograph should have a report written on it, and the report should contain your clinical findings, and it should mention the patient's dose and things like that. And I think it's worthwhile because generally patients' notes rarely go missing, and I'm saying that touching wood, but radiographs do. And it's always worth that if you have the information there from a previous radiograph, but you can't find the radiograph, that at least you have an idea what's there. So for instance, if you're describing the curvature of a root, even without the radiograph, you have an idea what's ahead of you. So I think it should be done for every radiograph. It is a requirement here, but I think it's best practice as well that we should be writing some sort of comment on the radiograph. For one thing, it helps with the justification process, because when we write a prescription for a radiograph, we're giving a reason why we want to take the radiograph, and the report then justifies that the radiograph was actually worthwhile to the patient. Thank you, Albert.
Thank you very much, Andrew. Thank you. We have, John Marley would like to come in, I think.
If I could add on to what Andrew has said, I think I would echo absolutely what Andrew has said about reporting, and certainly the need prior to any dental extraction to have a radiograph. Because when you think about it, if you go to the through the process of reporting on that, that's going to help inform your consent process for the patient. You, by dint of going through that process, will be able to say, oh, actually, I think this is going to be a little bit more tricky than I thought it was going to be. And thank goodness I have this radiograph. And you can even use it as an aid in discussion with the patient. So again, it's about information gathering. It's about formulating your plan, which in turn will help formulate the discussion with the patient in terms of consent. So everybody's on the same page before the process begins. So I would wholeheartedly echo what Andrea said, and in particular, the need for radiographs for all dental extractions, even the loose teeth, because who's to say what's causing the looseness?
Yeah, thank you very much, Sean. Thank you. Questions around next will be either for Jerry or for John. That is that removing lower impacted wisdom teeth is potentially tricky. Any particular advice as to, in practice, whether it's a no-go for a practitioner or whether it is something that one should have a go at, and where should one draw the line? Maybe if I ask Jerry, if you possibly could maybe give an answer to that. Thank you very much.
Thanks, Albert. It's a very, very important question. I would be cautious about using the term "have a go at," to be honest with you. I think whatever we do in our clinical practice has to be based on our training and expertise. If we stray outside our level of training and expertise and we have complications, that this can lead to bad outcomes for the patient, and it leaves us vulnerable as clinicians in justifying what we have done. So let me carry on to specific circumstances. So if we're talking about impacted mandibular wisdom teeth, if we're talking about which ones are easier and which ones are more difficult, and which ones may be addressed in general practice if there is no specialist support available. So, for example, a vertically impacted mandibular wisdom tooth in a younger patient, less than 25 years old, where the roots are not lying close to the infraalveolar canal, would be a reasonable impacted tooth to remove in practice. It's crucial that we do not misinterpret a disto-angular impaction for a vertical impaction, because this can lead to potentially serious complications. Because if we elevate a disto-angular impacted wisdom tooth thinking it's a vertical, it can result in a potential mandibular fracture. So again, the trend and the theme of what we're saying is very similar. A radiograph is absolutely essential. The root pattern is important, the age of the patient is important, the pattern of impaction is important. But by and large, removing wisdom teeth in general practice is probably not to be recommended unless the practitioner or clinician himself has some significant experience in that area. So, Albert, that was a little bit long-winded, but I hope it's addressed the question.
Thank you very much. Thank you, Jerry. We have a question for John. There is always a risk of the development of an oral-enteral fistula communications following the removal of maxillary molar teeth. Are there any advice that you can give to minimize that risk in relation to oral surgery practices, John?
So thanks again for that, Albert. This was touched upon, of course, in the complications lecture. So the same principles apply. It's assumed that you've gone through the diagnostic pathway, that you've arrived at a plan, and with that plan, you have some backup information, including your preoperative x-ray. So you'll know the age of the patient, and you'll know that the more elderly you are, the more or less rather elastic the bone is. So that's going to be a feature. Why? Because the force that you're going to apply to that tooth may be in excess of the force required to break the bone rather than rupture the ligament around the tooth. In addition, there may be elements of ankylosis in the older patient, and particularly in the lone standing tooth. And then on top of that, you have the level of numination of the sinus around that, because if the abutting teeth have been lost, then you can get inculcation and extension of the sinus around the tooth, which makes the bone even more fragile, and the risk of fracture of the bone around the tooth more likely. In addition, then heavily restored teeth that are likely to break, with a lot of secondary dentin in there as well. All of these things will conspire against you to create an oral antral communication. So forewarned is forearmed, as per the lecture advice. It's not a problem to have caused it if you knew it was likely beforehand. So make sure that you have all that information for you and ultimately for the patient, because you're going to have to discuss this with the patient, and then you're going to have to make up your mind that difficult question: am I going to do this, or is somebody else going to do this? And if they are they going to proceed directly to what we would call an elective surgical, where you lift a flap directly, remove the bone, section the tooth, and reduce thereby the possibility of an oral antral communication. And then on top of that, you have to consider the medical background, of course, of the patient, and the medications such as bisphosphonates, etc., that can compound the issue, as well as NOACs and warfarin and such like. So all of those things need to be taken into account. So, like always, if you work back upstream and have all that information to hand before you start, you'll have a good idea whether this is likely or not, and then decide, am I going to be the one to solve the problem if it happens?
Thank you very much, John, for the very comprehensive answer. We have got a question from the audience for Professor Kearns. The question for Professor Kearns is, when is it appropriate to prescribe antibiotics following exodontia? Thank you.
Thanks, Albert. This is a controversial topic, and there are two schools of thought. One would say that it's not necessary to prescribe antibiotics, and the other says, of course, it is. So, as a rule of thumb, in our unit, when we have to do a surgical extraction, raise a flap, drill some bone, and elevate some roots, we would always prescribe an antibiotic. If we do a simple extraction, forceps extraction, we do not prescribe an antibiotic unless there is some pre-existing infection. Now, there are clinicians who would say, well, if you raise a flap and drill the bone and take some roots out, antibiotics are not necessarily indicated. And if an infection develops as a secondary event, then antibiotics will solve that problem for you at that time. However, my view is that it's better to prevent a problem than have to deal with the problem as it occurs. So to summarize, if we lift a flap and drill some bone, we would always use an antibiotic. If we have a simple forceps extraction, we would not necessarily use an antibiotic unless it was infected prior to surgery. The choice of antibiotic would usually be penicillin, amoxicillin, or augmentin. If the patient is allergic to penicillin, we would tend to use clindamycin as a second choice antibiotic. So maybe Andrew or John would make a comment, but that'll be the practice in our department. Thanks, Albert.
Thank you very much, Sharon. Would you have anything to add, Andrew or John, in relation to this?
I'll be honest, Albert, if I put my oral surgery hat on, I would agree with Jerry completely. I tend to feel that once the flap is raised and you remove bone, you're exposing fresh bone to the oral cavity is not sterile. So I tend to feel that to prevent any infection there is better than to try and deal with it afterwards, because ironically the patient will always blame the secondary infection on you taking the tooth out, rather than maybe their oral hygiene measures after the extraction. So I would tend to be very cautious that way as well, but certainly a routine extraction, I wouldn't.
Thank you very much, Andrew. John, would you have anything to add on to that?
No, I absolutely support what's been said so far. Yeah.
Thank you very much. I've actually got a follow-up questions on the same topic, and which is that Jerry has mentioned amoxicillin and clindamycin. What about the role of erythromycin steroids and cafalexin? Have they got any roles to play in relation to this at all? Jerry, might be if you could give your opinion on that, please. Thank you very much. Thank you.
Thanks, Albert. Thanks, Albert. For patients who are penicillin allergic, there is a a small percentage of those patients who will also be allergic to cephalosporins. So we tend not to use cephalosporins in patients who are penicillin allergic. Clinical practice will vary in different parts, different units, different parts of the world, but that's our practice. As regards erythromycin, traditionally erythromycin was a second choice antibiotic to penicillin. However, we have found that patients develop a significant amount of nausea, sometimes vomiting with erythromycin, more so than with other antibiotics. And for that reason, we tend not to use erythromycin nowadays in our practices. Also, erythromycin can, as it is more modern first cousin classed, can lead to some interactions with other medications. So we tend to stay away from erythromycin at the moment.
Thanks, Albert. Thank you very much, Jerry, for this answer. A question has just come in, and that is that for lower first molar extraction, do you do a buccal injection as well as the inferior block? And why is that? And why do you not do that? Andrew, will you give an answer to that, please? Thank you.
Yes, certainly, Albert. I'll be honest, I always give a buccal infiltration to block the long buccal nerve. I think it's useful because the position of the mental nerve is highly variable in patients. So you tend to find that with a first molar, you may get around the mesial root might be numb because of the mental branch, but around the distal root isn't. So you tend to find if you proceed to a surgical, you run into problems trying to elevate the flap if it's not numb. So I would always give a buccal infiltration.
Thank you very much, Andrew. What about John? Would you always give a buccal infiltration as well?
So just to clarify, I think what we're talking about in terms of surgical removal or straightforward exodontia of a lower first molar, you're going to have to give a long buccal. Whether you want to then supplement that with a buccal infiltration beside the tooth or omit the long buccal and give a buccal infiltration, whilst it seems attractive, the latter, there is a risk that you can have issues with local vasoconstriction, which might predispose to a greater likelihood of a dry socket. So call me old because I am old. So generally I stick with a long buccal block and then the inferior alveolar nerve block and lingual nerve block, of course, at the same time.
Thank you very much, John. There is one follow-up questions on that is regarding the choice of anesthetic, choice of local anesthesia. What is your first choice of local anesthesia? What is your second choice? And the reason why for that? Jerry, will you be able to throw some light into that?
Sure. Well, first choice is lignocaine, 2% with 1 in 80,000 adrenaline. Is my first choice of local anesthesia. There's over the years there's been a lot of discussion back and forth about the use of non-adrenaline containing local anesthetics for patients who are potentially hypertensive, patients who are on other medications including monoamine oxidase inhibitors or other catecholamine promoting agents. But the issue about using plain lignocaine is that the duration of action is short, and the effectiveness of plain lignocaine is not as good as lignocaine with adrenaline. And so for that reason, if the patient experiences discomfort or pain during the procedure, they're going to pour out endogenous catecholamines, and that's going to sort of negate any theoretical advantage that we may have by using non-adrenaline containing local anesthetics. The other local that we use, especially if patients have surgery under general anesthesia and the surgery has been prolonged. So for example, a patient may be having a symphyseal bone graft or closure of an oral communication. We would very frequently use Marcaine, which is a long-acting local anesthetic at the end of the procedure. So we would use Marcaine 0.5% with 1 in 200,000 adrenaline, which will give local anesthesia for approximately 4 to 5 hours at the end of surgery. And that can be given as an intra-aortic block, a mental block, or an infraorbital block. So they're the workhorse anesthetic agents, lidocaine with adrenaline or Marcaine with adrenaline. I tend not to use plain lidocaine. Thanks,
Okay.
Albert.
Thank you very much, thank you, Jerry. What about yourself? Andrew? What about yourself then? What would you use? Would you agree with Jerry, or would you use something different?
I'll be honest, Albert. Lignocaine 2% with 1 in 80,000 would be the bread and butter, so to speak, and certainly for inferior dental blocks. I tend to use a lot of articaine with 1 in 100,000 or 1 in 200,000 for my buccal infiltrations or for extracting upper teeth where it's just an infiltration. There is sort of the theory that articaine is fat soluble, and so it actually permeates into the bone to some degree. So I tend to find, again, it's quite long acting when you give it, so patients get a profound anesthesia with it, and it gives you a bit of extra room to play with, so to speak. As Jerry had mentioned, a lot of patients, if they are feeling pain, they're going to get the sort of the atrial fibrillation and things. They get the shakes and things from their own adrenaline rather than what you've given them. So those would be my 2 main ones. I rarely use adrenaline-free local anesthetic. I've tried it on a few patients who are on bisphosphonates because there's some work out there that has suggested using adrenaline-free anesthetic for those patients could be an advantage, as John had mentioned earlier. So I keep a box of it handy just in case, just for the odd patient, but it wouldn't come out that often.
Thank you very much, Andrew. What about in your clinical practice, John? Would you be similar to Andrew, Jerry, or something totally different?
Yeah, I mean, I would echo what Andrew and Jerry have said. I mean, it's the workhorse is the lignocaine and adrenaline. I mean, you got to remember what you're trying to do here, which is to make it a pain-free experience. So you want to stop the pain before it starts, and that journey begins with the choice of local anesthetic. I would echo what they say about the adrenaline-free. You need to be fairly fleet of foot and have a good idea in your mind that this is going to be a flick-out job before you would use adrenaline-free local anesthetic. There is some recent work to suggest that there is a spectrum of phenotypes of people displaying the sodium channels, and therefore that a blend of local anesthetics in those cases where it's difficult to anesthetize, and that's where the buccal infiltration, for example, with an articaine injection supplemental on top of an ID block might be beneficial. I would echo what Jerry has said in the more difficult cases, i.e. the ones that are ending up in theatre under general anaesthetic. I would be making sure that we would kick off with lignocaine and adrenaline, but I would also finish the operation with Marcaine and adrenaline, because you're closing these gates and you're keeping them closed for as long as possible, because the post-op morbidity in terms of pain will be significantly reduced if you can do that. So pretty much the same as what my colleagues are using.
Thank you very much, John and Andrew and Jerry, for a very comprehensive answer to these questions. I've got slightly different questions now, which is COVID-19 is amongst the clinical practice. Fallow periods is a reality. Has it affected your clinical practice? And if so, to what an extent, and how do you manage it at the moment? If I possibly can come to Jerry first, what do you think?
Thank you, Albert. That's a very good, difficult, and probably controversial question with lots of different answers from different parts of clinical practice. So, if I would direct you towards that Scottish document, the SGCEP document, it provides a very, very rational and comprehensive discussion of fallow period, although strangely enough, in the introduction to the section on fallow period, they say we should have a pragmatic fallow period. And so that might lead us to believe that they're not really sure. But in fact, the truth is nobody is absolutely sure. But there's a very, very good flow chart in the ST-CEP document on COVID mitigation factors, which outlines different fallow periods depending on the procedure, the length of the procedure, the use of high volume suction and ventilation within the room. And so they have divided out procedures into group 1, 2, and 3. And so group 1 procedures are high risk for aerosol generation, use of ultrasonic scalars, air rotors. Group 2 are procedures which would be carried as an oral surgery practice, moderate risk, and then group 3 are low risk procedures. So, and the follow period varies depending on those variables. So this is not an answer which is an absolute yes or no or never type of answer. So the recommendation would be to follow whatever the guidelines are in wherever you're practicing, whether it's in the Republic of Ireland or the UK or other parts of the world as well. But I think as time goes on, our rationale for follow periods will be better defined, and our time for follow the periods will also be better defined. So in our practice in the hospital, when we remove wisdom teeth using surgical drills, we have a follow period of approximately 15 to 20 minutes. But we have the great facility of having adjacent rooms where we can move from room to room. That may not always be possible in dental practice. So again, Albert, a little bit long-winded, and I know Andrew and John will have some comments as well, but that's a very important question, and I'm afraid nobody knows the answer absolutely. Thanks, Albert.
Thank you very much, Jerry. So if I may come to you, John, in your clinical practice in Belfast, what guidelines do you follow? Do you follow the ST-CEP guidelines to the letter, or anything else that you do?
Yeah, I mean, as Jerry, I mean, I fully support what Jerry has said. In general, of course, all our clinical practices have been impacted by this. But of course, it's all these guidelines, as I mentioned earlier, are live documents and subject to change. And so the biggest change that's coming around the corner will be the vaccination. And that will clearly have a big impact on what we are able to do and what we consider high risk or medium risk. So at the moment, we're all working, for the most part, with medium risk patients, i.e. patients who display no signs of COVID, no symptoms of COVID, but who's to say that they're not asymptomatic spreaders of COVID. And so we have to follow the guidelines, as Jerry quite eloquently points out, in the areas of the world that we work in, using either our local guidelines, which presumably are informed by the national guidelines. There's no doubt about it, that has significantly impacted on all clinical work, and the knock-on effects of that are significant, both for undergraduate teaching, postgraduate teaching, as well as general practice and specialist practice work. And we're going to take a bit of time to get out of this, and we'll have some backlog to work with for those whose exposure to their clinical practice has been undermined as a result of this pandemic. And we'll all together have to put our thinking caps on as to how we work on that and help those individuals.
Thank you very much, John, for the answer. Andrew, would you have anything to add, or would your practice be slightly different in relation to fallow periods?
Thanks, Albert. No, I'll be honest, from the point of view of fallow periods, everything John and Jerry have said would ring true with me. I suppose one of the impacts on everyday practice that we certainly notice is that we're seeing less patients because we have fallow periods, and we're leaving extra time to don and doff PPE. And you also I've certainly experienced that depending on what the local positive count is, a lot of patients will not show up for appointments because they don't want to come to a health centre or a hospital because it's seen as a focus for the COVID virus. So they put off their appointments until times are improving, or they put it off until they're actually in bother that they have to get the procedure done. But yep, everything's slowing down. I think, as John mentioned, it's going to catch up with us eventually. So just waiting lists are getting bigger, and patient needs are getting stronger, but the more they have to wait for their appointment.
Thank you very much, Andrew. I completely agree with the three of you. I think that inevitably, whatever we do, we are stalling up problems for the future, irrespective of what we do at the moment, because the challenges we face are pretty much unprecedented. And how we manage it depends a lot on local factors, the guidelines, and others. And I think that, in fact, that if any of you had come into our annual scientific meeting, the online annual scientific meeting on the 31st of October, a month, 6 weeks ago, there was an excellent lecture on following period and SDSEP guidelines there, which was fascinating to see as well. And very little has changed from there, except that we are still in where we were from before. Now, I noticed as far as the time is concerned, and we have only got about another 7-8 minutes to go. So I'm just going to wrap up and put in another question that has come along, which is that how should we manage an oral enteral communications? We try our very best. We can't stop doing all the potentially risky procedure. And if we recognize there is an oral enteral fistula in the primary care practice, what should we do and how should it be followed up? So if I may come to John first. John, if you could give an answer to this question, please. Thank you.
So, if I'm correct in thinking, the question refers to an oral enteral communication, a fresh oral enteral communication.
Yeah,
and
fresh oral enteral communication. That's it. Yeah.
And we assume we have recognised that for the through the methodology we've described in the lectures. Either we can actually see the communication, we can hear the communication and the difference in resonance when we put the sucker tip across the socket rather than up the socket. And there's no forced expiration. We don't do that trick anymore because that could make a bad thing worse. So if it's there and we can see it, the likelihood is it's not particularly small. So we're going to have to do something about it. And so the decision-making process is whether you as the practitioner is going to do something about it or somebody else is going to do something about it. It goes without saying that presumably as part of the plan, you were aware that this was a risk that you've explained to the patient. And that as it's happened, then basically you're going to have to explain to the patient this has happened and here's what we're going to do about it. And if you're a practitioner who is willing and has sufficient experience to do it, then the recommendation would be to use a buccal advancement flap. But you wouldn't be doing that unless you were doing a number of those or have had exposure to them fairly recently in the past. And the buccal advancement flap is by way the most straightforward one to do. It lends itself to the general practice environment. But you'd have to think seriously about whether you're the person to be doing it. If you've gone through the process upstream where you know that this is a possibility and you forewarned the patient, there's no reason why you couldn't put a simple Surgicel dressing in the socket, not stuffed up the socket, but just at the mouth of the socket. Maybe a mattress suture across the mouth of the socket to support that, to allow hematoma to form. And particularly if it's a small oral enteral communication, that might be sufficient together with the usual post-op instructions. But if it's big enough, you would still do the same thing, but you'd lift the phone to your local friendly oral and maxillofacial surgeon or oral surgeon practice to be able to take that on. And they're prepared and ready to go to deal with those, and they'll do the buccal advancement flap. So it goes back to the same thing. Forewarned is forearmed. If you've told the patient in advance, it's an explanation. If you're telling them afterwards, it's a bit of an excuse, but you can still get out of jail free. But you have to stop what you're doing, be forthright with the patient, be in control, be calm about what's happened, and take the appropriate measures that I've just described. And you won't go far wrong.
Thank you very much, John, for the very comprehensive answers there. Jerry, would you have any thing to add on to this, or you quite happy with that? Or
I, I absolutely agree, Albert, and indeed John covered this topic very, very well in his lecture. The oral-answer communication is always very challenging if you're in dental practice. Um, we always have to have an x-ray before we remove an upper molar tooth, always. We always must warn the patient before we take out an upper molar that there is a risk of an oral-answer communication. The vast majority of oral-answer communications resolve spontaneously. When we think about oral-answer communications, in my own mind, we have two categories. Category one is where you take out an upper six and you're a little bit concerned that there may be a communication or not. And so you do exactly as John has described, and you give some antibiotics, some decongestant, some Octavine, and some analgesic. You see the patient 1 week later. If there's an oral communication at that time, you write a letter or you phone your local specialist and say, I have a patient with an oral communication. Can you see the patient with a view to closing this? Very straightforward. The second situation is where perhaps you're taking out a lone-standing molar in an older patient, and you have a tuberosity fracture and you have a large oral communication. If that happens, and you've taken out the tooth with the bone with it, and you have a large communication, well then that patient should be referred straight away to the hospital the next day or the day after, not as an emergency, but as a sort of an expedient referral. So there are two aspects to this. The smaller one that is possible but unexpected, and then the large one which must be managed straight away. The whole essence, in my view, of oral communications is that the sooner they're closed, the less is the risk of them becoming chronic. And when you get a chronic oral communication and a fistula, you can develop sinus problems, and the problem becomes much more challenging to deal with than if the communication was closed at a very early stage. So that would be my views, but very similar to what John has said, and very similar to what John has covered in his lecture. But by the same token, it's not appropriate for every upper six to be referred for specialist care. We have to carry on with our practices in an appropriate way. Thanks, Albert.
thank you very much, Jerry. Maybe the last bit, it brings up to the last bit of one semi-fresh question, if I could address to Andrew, which is that if you're concerned that there might be a bleeding tendency, would you do a mattress rather than ordinary suture? Andrew, what do you think?
Thank you, Albert. I'll be honest, yes, I would normally, if I'm concerned about a bleeding tendency, I would, as John had mentioned with the oral communication, I'd use a bit of Surgicel or some of these sponges like Gelatamp and things that can be used as a coagulation aid. And I tend to find if I put something like that in a mattress suture, will hold it in the socket better than two interrupted sutures, for instance. And certainly a trick you can do is you can sort of crisscross your mattress suture so that you can hold the dressing in place. There are occasions when the two interrupted sutures works better. Sometimes if I've lifted a large flap or something, I would use interrupted sutures just to get the papilla to sit in the correct position. But I like mattress sutures if I think they're a bleeder.
Okay, thank you very much, Andrew. On this note, there, I think that we are coming very, very close to time. I'd just like to thank, on your behalf, the fellow members of the panel, Dr. John Marley, Dr. Andrew Bolas, and Professor Jerry Kearns for their splendid contributions to tonight's discussions, as well as the splendid delivery of this particular program. I know that has been a lot of thoughts put into that, a lot of thinking, a lot of preparations, and we would like to thank Dr. Marley in particular for spearheading this particular program itself. There, I'd just like to say thank you very much for you for participating in our program. Thank you very much. You've experienced the first flipped learning that we have designed for you. We hope that you have found it useful and beneficial. This is the best, of course, that we can do in relation to the environment that we are in, the limitations that we are in. But I'm very pleased to see that amongst the participants of you there, they are colleagues from Ireland, from outside Ireland, the UK and the rest of Europe, and they are also colleagues from the Middle East and Asia as well, taking part in this seminar. And I would just say that we thank you and we wish you safe and we wish you a very happy festive seasons. And we hope that you look after yourself. Faculty of Dentistry, Royal College of Surgeons in Ireland welcomes you, like to have you on board with us. And I would be very, very happy to see you all face to face sometime in 2021 or maybe after. And until then, we just say goodbye to you all and thank you very much. Have a good festive break. Thank you. Bye-bye.